What I want to talk to you about briefly, I have about 15 minutes, and so I will prioritise in terms of some of the slides that I have about some of the work we're doing on the development of what we're calling a policy framework on what we initially started to call a policy framework on public health, and we're framing slightly differently. As was mentioned, the Ministers Riley and Fitzgerald, together with Ministers Lynch and Shortall, launched this, and we did this in reverse. Normally we'd start with the work on something, produce it, get it to a point where it was ready to be launched by a minister and then launch. This one we kind of, without doing any work, we started by launching. And part of the reason for that was, I think our analysis, and I think it's a correct analysis, was that we needed to do something to energise and to bring some focus on the whole area of public health. As I'll go on to say, I think our consultation established in something I think we probably all know, the lack of focus on the development and on public health, and the lack of a sense of direction for many of the people who work, particularly within the health sector in this area, had led to a situation that in morale terms people were at something of a low ebb, and something needed to be done to try and create some initial engagement with people at the beginning to suggest that there's something real and different. Our analysis is not that different to what it would have been over the course of the last 5-10 years, as long as I've been around in the Department of Health. What was different on this occasion was a sense of political engagement with the analysis that we put together. And yes, it wasn't in the original programme for government, but we did get ministers to listen about the need for something like this very shortly after the government took office, and that was something that I'm encouraged by and gives us a mandate to do some of what we're now doing in this space. Very briefly, and again, context was mentioned. Life expectancy, we've seen significant improvements. We've seen significant improvements in cause-specific mortalities for all the common chronic diseases in this country. We've seen that then feeding into improvements in morbidity or changes in the patterns of morbidity. In some cases we're left with the consequences of the survivorship from chronic diseases as distinct from the mortality, which would have been our experience in the past. People would have died from cardiovascular events, people would have died from cancers. They now live with the consequences of the complications of those diseases and their treatments. That's a challenge we have to face. Healthcare associated infections, these are all part of our lived reality. And even though we're improving, and we can demonstrate significant improvements in health as a population, there is a substantial case for us to change what it is we do and to begin to, the term upstream is used, and that is the term that's used, to intervene earlier on the factors that are shaping the health experience of our population. We know the burden of disease is going to change because, for the most part, the common chronic diseases that we face, like most developed countries, are heavily age-related. Our population is getting older. So it stands to reason that we will see significant increases in the numbers of cases diagnosed and presenting to our health system, all other things being equal, out over the next 10, 15, 20 years, as far as our population projections allow us to project. And so, to put that in numbers terms, that's an on average over the next 20 years increase in the number of new cancers diagnosed in our health system of about 5% each year, every year. And the same thing applies to common chronic diseases like diabetes and cardiovascular disease. And to some extent, we'll be limited in our ability to get ahead of that in terms of pure initiatives in relation to things like health promotion and prevention, simply because of time. And that for some of these individuals, you could argue the die is already cast. You know, if we're talking about cancers, the diagnosis may not be made, but the condition may already exist for people who will be diagnosed in 5-10 years' time. We have significant imperative to change in terms of team working, specialisation, and other factors that are changing our sense and our perception of what it means and how we best organise ourselves to deliver good quality care. There are a number of other developments, and in the interest of time I'm not going to spend a lot of time talking about all of these. In the past, the challenge was to provide technically effective episodic care for individuals at the point at which they developed complications or conditions. The challenge now for a healthcare system is much more about providing lifelong, continuing, coordinated care that emphasises things like prevention, early intervention, and when chronic conditions arise, to provide the most appropriate care in the most appropriate setting for those things, and that our reliance on hospital-based care and technical expert care is something that's properly coordinated and, in the modern term that's being used internationally, properly integrated. It's a term that's used quite a lot and not really very well understood in my view. But that's a substantial challenge and leads us to a conclusion, again in my view, that the only really way that we can properly provide for all of those challenges in a truly integrated sense is through a sense of the primacy of primary care. That if the fully developed, as we've heard earlier on, what a fully functioning primary care team might be is the only means through which we can coordinate the complex requirements of individuals and families in an era of the kinds of challenges I've talked about in terms of chronic disease. That's as much as I could talk for at length in relation to that. The other issue I think we need to focus on is the fact that, for the most part, most of these common chronic diseases are preventable. And what's more, we know what the causes of these common chronic diseases are, and they mostly relate to 7, again, preventable factors, for the most part. And so a substantial burden of the healthcare challenge that we face is actually something we could prevent. Now, saying that may be true, but doing it is something very, very difficult, and that's the challenge I think that we all face. And what I would say, and I'll come on to try and point out, left to ourselves in the health sector to solve this, we will not be able to do it. And this is a whole of society and a whole of societal problem that we need to frame this problem in societal terms if we're to find the kinds of solutions that we need. If the solutions are seen as being about more and more effective, technical, expert hospital-based services and issues really in relation to access to those services, if we define the problem only in those terms, then we won't manage it effectively. So just to move on, you've heard some detail, I know, in relation to the programme for government, and a number of major elements of that in relation to healthcare. A substantial reform, and as I came in I heard Liam from the HSE talking in some detail about aspects of that from the perspective of the HSE. A substantial reform of both the structure and financing of healthcare, designed to bring more fairness and transparency into how the system operates, with some emphasis in the programme for government around structures, around the establishment of hospital trusts, the establishment of a patient safety authority, and so on. And comparatively little, and this is not necessarily a criticism, emphasis on some of the elements that we would regard as being related to public health. What's there and the value is in relation to primary care and the substantial amount that we are focused on in terms of developing primary care. But as I say, the political response to the analysis that we would have had as a department in relation to the priority that we must now begin to accord to public health was encouraging. We know the Minister announced just before Christmas the establishment of 7 new directorates within the HSE. We are still, as I'm sure you know, in the process of working out what that will mean and how best to organise, and how to do it in a way that doesn't challenge what integration and coordination of service delivery may already exist. We don't want to fragment that, but we do want to make sure that there is, the move in the direction of separation of provision, in particular, of hospital services as distinct from primary care, as distinct from, etc., that move is affected. So our policy response to those challenges as a department was to identify the need for us to develop an all-embracing public health policy. We gave it the working title, and it is very much a working title of Your Health is Your Wealth. We've tied it in as much as we can practically do so into work that's happening at an international level through the WHO. And the interesting thing is that a lot of countries quite recently are doing either new work or updating work in this area right at the moment, or have done so very recently, like England, for example. Northern Ireland are doing, as I'll come on to mention, some work in this regard right at the moment, almost alongside us. And part of the reason for tying it into the WHO is it gives us, in a pragmatic sense, access to a lot of expertise and resources the WHO is bringing to bear on their international analysis, which is largely focused on many of the same kinds of problems: the burden of chronic disease and the unequal distribution of both the expression of that disease, the lifestyle-related risk factors that relate to it, and the causes of those causes that are behind all of that. And so the analysis is much the same in most countries of the problem that we're seeking to face. The methods that we have chosen, we didn't establish in the kind of classical sense an expert steering group, but what we have established is a group of people largely drawn from the HSE, but particularly and the department, particularly supported by the Institute of Public Health and some others, to create a working group to do the background work, if you like, to pull together a policy document that would be developed through a process of consultation, as much consultation as we can feasibly manage, and to present that as a set of policy proposals to government. And that's the process, if you like. I'll come on towards the end and give you a sense of precisely where we're at in time terms and when we hope to complete all of that work. So the analysis that the working group is basing its proposals on is based on 4 strands. The first strand, and they're set out there for you, is a so-called SWOT analysis, and we're using a framework from the WHO around what they call essential public health operations, of which there are 10. And we're using that same framework for the purpose of applying, as it were, a common subjective assessment to, or sorry, objective assessment to our subjective evaluation of our system. So it gives us a clear framework to do that, and the consistency with the WHO allows us to make some sort of comparisons, perhaps, both with the WHO and across other countries. We've conducted a fairly substantial consultation that consisted of the national launch that I mentioned, 4 regional consultation meetings that happened very shortly afterwards. The invitation, if you like, and participation was cross sectors as much as we could generate that in those consultations. We also had invited submissions a period of time beginning around the end of the summer and up until the early winter, and have completed an analysis of all of those, and largely thanks to the IPH that analysis has been completed. It's very, very good work, and if you're interested in it, it's available for you to see on our website. We're also doing a substantial review of the evidence in relation to a lot of this, because we'll be in putting forward proposals to government to challenge to provide some of the evidence base, and Sinead in some of her presentation alluded to some of the kinds of material we're pulling together as part of our evidence, and we'll have a separate report on that. It's almost complete. Similarly so in relation to international models, or what's working and what works in other countries, and drawing on, again, some of the examples I heard from Sinead, Norway, Canada and other jurisdictions. I've mentioned the strands of the consultation. In the interest of time, I'm not going to go into that in detail. As I say, they're available through our website and the website of the Institute of Public Health. Definitionally, the work is focused on 3 broad areas. It's not saying that this is how it's going to be presented, but it's focused on what would be the traditional areas that the staff who work in public health would be focused on. I'm not going to say a great deal more about that. The other thing to say is that we recognise that there are a number of policies in development and at an advanced stage of development, or planned to be developed. For example, the government only this week, Tuesday, decided we are going to have a national early years strategy, so we see that as a very important thing to be tying into what we're doing. And work that's happening in other sectors that's relevant, we're trying as much as we can to try and connect these things together. What I want to try and focus my time on is giving you a sense of where at least I see some of the emerging recommendations. I mean, it should be stressed that what we require as part of the process that I have outlined to you is to bring these to government and through the government decision-making process, and ultimately get government approval for what we will launch. So in a sense, I'm not able to say for certain exactly what government's going to sign up to. That's part of our process that we're going through. I'll give you a feel for some of them. One of the things that we've identified is the need for us, again, in improving our knowledge and our knowledge base, to develop a common data set. Now, we have lots of sources of information on health and health status in lots of different places, but what we don't have is a clear, consolidated, pulled together, if you like, national public health common data set that is used and accepted by everybody as the description of the health status of the Irish population or subpopulations. And we're going through a process to try to create that and to create a capacity to report on the basis of that. A lot of good work has already been done in this space, again through the Institute of Public Health, and in particular focused on Northern Ireland. But it's something that we want to bring some greater visibility to. The other is a decision that we've taken as a department as part of all of this, that whereas we would have had national lifestyle-related survey methodologies in the field, so to speak, in a lot of different ways, we see the need to consolidate those into a single national annual health and well-being survey methodology, which is something that we're in the process of developing and would hope to conduct for the first time this year. And we would see this as taking the place of SLAN and other survey methodologies that we've invested in. And our contention, and I think there's some reasonable evidence to support this, is that we think we could get better data, avoid some of the debates that often take place between different people about the actual data and which is correct and what's not correct, and do it at a lower cost. And so that's something we're going to do. I mean, the one that I would use to illustrate that is the issue of smoking. I mean, we have at least 3 methodologies that the taxpayer funds in different ways to measure our smoking prevalence. So depending on your requirements, you can have a smoking prevalence of between 23 and 31%. I mean, I think that's not good enough in terms of research and information for action, and it's costing us more than it would cost us to have a single process and all of the necessary actors buying into that and everyone accepting that we measure smoking in one way and there's only one, in a sense, correct methodology for that. Substantial potential, as I say, from North-South cooperation. Without going into that in great detail, suffice to say that at a political level and an official level across the border, we've had excellent cooperation and working with our counterparts in Northern Ireland. There's a lot that we can do together on both sides of the island. That's not in a political space, and that's about practically recognising the fact that we share a single island and we have a common land border, and many of the public health challenges that we face on either side of the border are identical. And the final strand that I'll mention in relation to this is in relation to inequalities. We did some work with Professor Marmot, who was mentioned earlier on. We took a decision that we're not going to, in fact, attempt to replicate the scale of the Marmot. In fact, it was something he advised against and didn't recommend it to be a good thing. But in any case, it was something that we weren't necessarily planning on doing ourselves. What we're seeking to do is to try to create a capacity for us on an ongoing basis and to get agreement across government for this, to have a single strand of reporting of measures that we know are valid and reflect that are good indicators, if you like, of the kind of challenge we are trying to overcome, and to have that small set of indicators reported on at a variety of different levels, national, local and regional. And a particular focus for that we see in terms of our recommendations, and I'll come on to mention this in a moment, is the Cabinet Committee on Social Policy, which brings together under the chairmanship of the Taoiseach all of the social policy ministries. And we think that by creating a flow of information which is valid, which is evidence-based and which feeds in on an ongoing basis into that, it creates not in and of itself action, but it brings a much greater, if you like, visible transparency to the reporting of the kinds of data that you were referring to, Sinead, in your presentation. Another strand of recommendations relates to the creation of a common brand and charter for health and well-being. And at this point I want to sort of step out and talk about the change in terminology. We started out by calling this a framework for public health, and that's not the term that we use any longer. And part of the reason for that is that we found that the term public health was getting in the way, and our consultation said that to us. And at the very least of it, people had different understandings as to what the term actually meant. So for some people, usually within the health sector, it meant a group of professionals, or it meant a structure like a public health department or something. To the man on the street, it seems to mean the hospitals and other services. So something like health and well-being we see is much more neutral term. It has a sort of a face, there's something self-evident about it, that you're more likely to get a common understanding as between various different people as to what that might actually mean. Having said that, we're not saying that this is the final term that we're going to use. We're still in the process of trying to identify a single, brand for all of this. The purpose of a brand is to have a mechanism whereby all of, and I don't need to convince an audience, I think, of this or spend time even making the case that health and well-being has so many different stakeholders, and it creates such a substantial challenge then to kind of create a situation that we're standing in Croke Park, the headquarters of the GAA. Health and well-being is just as much about what the GAA does as it is about what I might do or what our general practice service might do. But how do we create a mechanism through which we can all visibly, if you like, support a common objective around health and well-being? And that's what we're seeking to try and do. And we're in discussions with a number of organisations to start off, if you like, with when we launch, with some practical examples of partnerships under that brand. The other thing is that the survey I mentioned to you a moment ago would become our national, whatever the brand is going to be called, survey. And so it will create some visibility around that brand, and to create a charter for organisations, and to challenge people to sign up and to support, and to give them a means of affiliating themselves with a common objective around health and well-being. And that's part of building that sort of alliances across other sectors. I mentioned, and the WHO uses the term governance for health, and any of you familiar with Ilona Kickbush's work at a WHO level would be familiar with that term. Suffice to say, it's I mentioned the Cabinet Committee on Social Policy. We see that as being essential, almost to the point that if such a thing didn't exist, we would be recommending its creation. It brings together all of the right ministries from transport and education and justice and children and health, environment, as well as and social protection, as well as the Taoiseach, and gives us a key, if you like, political forum in which to move on some of the agenda. So creating and mandating flows of information to a Cabinet Committee on Social Policy is a lot of what our focus will be about, to try and bring that visibility in a cross-sectoral space. And it's trying to, and I think, I hope you would all accept the need for this, move us from a situation where we frame the problem that we're seeking to address in intersectoral terms and not just in sectoral terms. We're very good at in this country is framing problems in sectoral terms, defining them as this is a problem in the education sector or in the health sector, and then effectively only mandating sector level responses and then wondering why it doesn't work. So defining that as the challenge is easy. Fixing that problem is difficult. Most countries in one way or another have struggled with, and I'm not aware of any country that has particularly cracked the issue of intersectoral working around health and well-being. Some clearly do better than others. But I think there's no single example out there that we can sort of, as it were, take, borrow and implement and as it were, overnight transform how we do things here. A lot of our focus then in terms of governance for health, for understandable reasons, is focused on what we're calling the operational system for health and well-being. In other words, how we organise and provide for, within the health system, those people whose day and daily job is in this space, time. Yes, okay. It's something we're all short of. And without getting into that in any great detail, that receives, comparatively speaking, more attention than you might otherwise expect, given its importance, but it's really about where are people going to be placed, given the breakup of the HSE, how are we going to provide for that organisationally and so on, and that's part of our remit. Capacity and workforce is very important. A lot of focus here this afternoon on jobs and the public service, quite rightly. This, as much as any other area, is a knowledge-based activity, and we need people with expertise working as part of all of this. But one of the things we need to try and also see as part of our challenge is how we engage civil society, and to not always see our only capacity to respond by, or to create capacity, is to simply employ more and more people. In fact, some things are done much, much better by way of generating that kind of spirit of volunteerism, and that's something that we're focusing some proposals on. The area of leadership, very important, particularly in terms of intersectoral working. We've had a lot of good examples in our system up to now of leadership development programs across sectors and so on. It hasn't necessarily bedded down into an all singing, all dancing, health and all policies capacity, which is what we would like. But the development of a leadership capacity is something that we're focused on making proposals in relation to. Of a capacity in legislative terms, which will give an underpinning, as we would wish, to health and all policies approach, seek to consolidate a lot of existing legislation that we have, some technical legislation in the areas of infectious disease and to do with international health regulations, and also provide for some of the governance changes that have to take place from the HSE, which is the current organisation that provides a lot of these functions, into a new future, whatever form that takes. As a final product, it will be a single document which will consist of the analysis I outlined, a plan and an implementation arrangement, supported by some of the background documentation that I mentioned. But I just finally leave you with a key message that this, in the way in which we're framing it, it's the first time we've ever had a policy on health and well-being in its widest sense. It is an opportunity in a once-in-a-generation sense, and because of all the work that's happening in reforming and reframing and restructuring the health service, it does give us an opportunity to ensure that some of this is part of what we do. It creates a substantial challenge for us, though. We need to ensure that, I know there's been a lot of talk on universal health insurance. The way that universal health insurance goes reflects the needs of our system around some of the things that I've talked about, and is not just a technical exercise for reforming how money moves around the system as things stand, but it is transformational in its capacity. So, in the interest of time, I will stop at that point. There's lots more I could say. 15 minutes was quite a challenge, I have to say. So, okay.